Well, welcome everybody to the Canadian Primary Care Research Network Learning Series, Workforce Strategies Needed to Advance Access to Primary Care. My name is Ruth, and I'm an associate professor at Dalhousie University. I'm here introducing the learning series on behalf of the Canadian Primary Care Research Network. Our mission is to facilitate research to spread and scale primary care innovations, to build and grow local practice-based research and learning networks, and to develop a pan-Canadian primary care information system. As the Nova Scotia member of CPCRN, I'm based in Mi'kma'ki, the ancestral and unceded, as well as present and future territory of the Mi'kmaq people. I also want to recognize that African Nova Scotians are a distinct people whose histories, legacies, and contributions have enriched this part of Mi'kma'ki, currently known as Nova Scotia, for over 400 years. Given today we'll be focusing on workforce, I want to offer a reminder that it's now been a decade since the Truth and Reconciliation Commission called upon all levels of government to increase the number of Aboriginal or Indigenous professionals working in healthcare, to ensure retention of Aboriginal healthcare providers in Aboriginal communities, and to provide cultural competency training for all healthcare professionals. I also want to mention that specific to primary care, just this year, the Our Care initiative undertook widespread public consultations and released a standard challenging governments to ensure that everyone receives culturally safe care that meets their needs from clinicians that represent the diversity of the communities they serve, among other key recommendations. So this workforce theme featured strongly in an African Nova Scotian community roundtable, and it's one we can consider in our discussion of workforce today. Without further delay, this is the first of 3 sessions that will focus on the persistent but also pressing issue of access to primary care now and in the future. And workforce, like reading, is fundamental. So integrated approaches to planning for workforce needs and for training and equipping clinicians in team-based primary care delivery are both needed. Fortunately, our presenter has been very busy leading initiatives in both these areas. So today, Ivy will provide an overview of the Team Primary Care Interprofessional Collaborative Table, which brought over 20 primary care professions together to align training. She'll also describe an integrated primary care workforce planning approach and a toolkit developed in the Ontario context. Ivy's accomplishments and leadership roles are too many to list, but some are included in the workshop description. From my perspective, Ivy has been a leader modeling really tireless commitment to calling for better evidence and data within a political space of health workforce. And I've admired her commitment to interrogating structures of power relevant to workforce, especially gender. So I'm really looking forward to learning from her today. Without further delay, I'll turn it over to Ivy. We'll hold questions till the end, but those should be plenty of time for us to discuss the content together. Over to you.
That's wonderful. Thank you so much for such a gracious invitation and introduction. So I'm just going to share my screen and hopefully everybody's seeing that. So just thumbs up if you are seeing everything okay. Good. Okay. Excellent. So yeah, I want to be talking to you about Team Primary Care Training for Transformation with your network. And one of the things to first of all acknowledge, I'm coming to you from Ottawa, unceded, unsurrendered territory of Algonquin, Anishinaabe First Nation folks who have been the caretakers of this land, past, present, and future. So do want to acknowledge that. And the elements of the Truth and Reconciliation Commission that Ruth so importantly stressed was something that we very much integrated into Team Primary Care. So I don't think that I need to make a case for why team-based primary care to this audience, but just very briefly, we know that there's a crisis in access. We know that it isn't just a solution to produce more, and that if we are going to have teamwork as one solution to really optimize all of the different roles that different primary care practitioners can play, training is needed to work together. And we took our inspiration from this quote from the Romano Commission. If healthcare providers are expected to work together, it makes sense that their education and training should prepare them for this type of working arrangement. And I will foreshadow one of the biggest lessons learned for me I'm not a clinician, I'm not a clinical educator, is how little each of the different practitioner groups know about each other. And so that seemed to be really fundamental for us to address. So Team Primary Care was a unique and timely initiative funded by Employment and Social Development Canada through their Workforce Solutions program. It was a 17-month project, started in November 2022, ended in March of earlier this year. So it was wide-reaching and very intense, very much focused on training primary care practitioners for more effective team-based care. So this is how our vision, mission, and principles evolved over time. So our collective vision, which is something beyond what Team Primary Care was about, was an integrated health system in which every individual receives equitable, high-quality, comprehensive primary care from a well-trained, well-supported, and optimally utilized team. So our mission to achieve that vision was to transform primary care training and education, at least to nudge it in the right direction so that we could better equip Canada's workforce for more effective team-based care. We really wanted to do so in support of the 4 primary care core functions of being first contact, comprehensive, coordinated, and with continuity. And that we wanted to embed 5 principles in primary care education, which I'll explain a little bit further in the next slide: interprofessionalism, equity, diversity, inclusion, and accessibility, truth and reconciliation, psychological health and safety, and social accountability. And this is just a little bit more detail about how those were embedded in the different programs. So enabling excellent healthcare through interprofessional teams, educated and supported to employ effective collaborative practices and processes, instilling humility and reflexivity along the principle of equity, diversity, inclusion. And similarly for truth and reconciliation, so that our work would be informed by Indigenous values, ways of knowing and healing, integrating knowledges of past and present wrongs, and reconciliation being integrated into various programs, embedding a culture of civility, respect, and psychological health and safety, which is really needed for teams to be able to function well together, to bring sometimes controversial issues, crucial conversations, as they say, to the table for more effective teamwork, and that there is an overarching principle of social accountability that incorporates those different dimensions. So I'm just going to walk you through the framework for Team Primary Care, how it evolved. So this was not something that we had at the beginning. It took us actually some time to get to this point. So we said training is essential for successful primary care reform. And we looked at it in terms of the different building blocks, that there would be practitioner-focused pre-licensure training, as well as post-licensure training, and then team-focused training. And so we needed to build from the ground up. So for these first 2 layers, practitioner-focused pre- and post-licensure training, we gathered all of those folks together in the interprofessional collaborative table, which I'll talk about in a moment. For the team-focused training, they were gathered together in the team optimization table. And then each of those tables and all of the teams were supported by cross-cutting resources that reflected the principles. And then we embedded ongoing developmental evaluation into that entire team. So those are the layers that I'll be walking through. So I'm first going to talk about the interprofessional collaborative table. So pictured here is our collaborative table and who we all included. So it's really important that that you see this as an unprecedentedly inclusive initiative. We were all pleased to experience everyone working so collaboratively together with this shared vision of Team Primary Care. So this collaborative table became a forum to share and align curricula, both in 2 kind of different dimensions. One is an aligned primary care curricula, and also that was embedded with these different principles. So along these different 20+ practitioner groups, again, to advance learning about, from, and with. And I underlined the about because, as I mentioned at the outset, it was remarkable how little some of these different representatives who were educators and educating these different practitioner groups really knew or didn't know about each other. So that seemed really critical. So here are just a few examples of the provider-focused education to develop sort of primary care role. So one of the first here being sort of primary care nursing role. And this was very much sort of fostered by the Canadian Association of Family Practice Nurses, because there are no requirements that those who go through nursing training as registered nurses have any experience in primary care. And so this was developed as a post-licensure program that can be integrated into pre-licensure. Similarly, for interprofessional dietetics education for team-based primary care. So providing some courses and micro-credentials for dietetics education, again, largely post-licensure to be integrated in pre-licensure. And similarly for the physician assistant primary care workforce integration. And in addition to creating modules about primary care, also creating modules about the different principles. So those are just three very specific examples. So in addition to all of these different projects who were around the table aligning their curricula, we had a curricula for the interprofessional collaborative table. And so there were these different articulating elements. So we first of all started with a synthesis of what are the different comprehensive primary care domains. And Dale McMurtry led that from a variety of different sources and really brought it together into a synthesis document that everybody around the table contributed to and could see themselves in that. Then there was a mapping of the scope and competencies to those domains. And there were a number of aha moments in that regard. And then we talked about the alignment of learning objectives, core competencies, and accreditation standards. And then we just started with the accreditation standards conversation. So first, in terms of the synthesis, there was an overarching approach. It was defined into population-based comprehensive care domains across the life course, and then associated services, which were divided for that first step. So going into a little bit more detail, these were the identified comprehensive primary care domains. So again, in these kind of buckets of community and patient focused, comprehensive services, and then across the life cycle. And I'm going to first of all take us through just one example that we walked through with all of the different teams, and that is in the case of chronic care. So we took these three examples: chronic care, maternal, neonatal, and well baby care, older adult care, and we created a set of tables where everybody could contribute to what is it that you do that could contribute to primary care in these particular primary care domains. So here's an example of what we did with chronic care. So we requested that each project and partner describe their roles related to the services within each of these domains. They worked individually within each project to refine what this was, and we developed this table where everybody could see it and have conversations about, oh, I didn't know dietitians did that. I didn't know occupational therapists could do that. So this was a really useful tool, and there were three of these that we created. And all of these are going to be integrated into a compendium document that we are going to be releasing, which I'll talk about in a little bit further. So if we come back here, the second topic, or the third topic here, is that within professions across Canada from pre and post licensure and across professions, there was this alignment of learning objectives and core competencies. And so in the next slide, this is the tool that we use to do that. So we said within a particular domain, what were your learning objectives, core competencies, and how did that map to accreditation standards so that we could use this and develop a common language for alignment. And so, for example, learning objectives would be gaining foundational knowledge, skills, and behaviors, understanding and applying primary care scopes of practice, competencies, and roles, and improving communication and interprofessional collaborative skills. So again, there was a focus on primary care competencies and quite specific to interprofessional primary care. So many of the programs, and it's a requirement by accreditation that they have some type of interprofessional training, those were by and large not in primary care. So there was this need to do both things, the primary care specific competencies and the interprofessional competencies. So the core competencies was aligning with clinical skills and key tasks, a holistic health and wellness model. And again, a lot of the practitioner groups felt it was challenging for them to take this very sort of task-based oriented approach where it's felt very listy. And so there was some creative tension to ensure that they're still maintained this holistic health and wellness. The Canadian Interprofessional Health Collaborative Framework, which was being refreshed at the time of our work, and there was a lot of good back and forth, including developing skills in communication and collaboration, some of their core competencies. But again, that what had to be overlaid into a primary care specific context and applying comprehensive scope of practice and abilities in any primary care context. And some of these core competencies were developed as part of their TPC project. So those 20 practitioner groups around the table, each of them had a project. I would say at least 3/4 of them had a project. Some of them undertook a project without funds from Team Primary Care in alignment. And there were teams that participated and saw the value of their aligning to these initiatives. And again, we started and we initiated a conversation with accreditors, bringing them together to understand what it is that we were trying to do, with Team Primary Care. And that would just initiated a conversation about alignment. So lots of conversations started, adjusted people or nudge people in the right direction, but we still need to continue these conversations. As I mentioned, one of the key products that we are developing out of the IP Collaborative Table is, in addition to the comprehensive primary care domains, we're developing this compendium of roles of each practitioner to enhance integration and another way to learn about, from, and with. We updated during this process, so Team Primary Care Funds enabled us to update the Introduction to Health Occupations in Canada text and to translate that into French. And this is a freely available text. I'm happy to discuss that with you. It's very academically focused. And so what we're trying to do with the compendium is make it very practitioner focused. And we drew some inspiration from additional documents from AFTO and from Primary Care Interprofessional Team Toolkit from Shared Health in Manitoba. So this is coming soon. So each of the teams is contributing to a 1,000-word summary, which includes vignettes about how they might contribute. So it starts with a story, gives some details, and it really is a starting point to enable and support that integration. I'm just going to touch upon briefly also the team optimization table and how different teams were funded to bring new partners into their teams and provide training for that. So this was a forum to discuss the essence of teamwork in primary care and how training would have to happen in situ for teams. So there are kind of 4 different types of teams that brought new skills in or new clinical domains into existing primary care teams. Some teams focused on improving their teamwork through training. Some training to provide enhanced skills. So these were cross-cutting teams. And some looking to expand the skills or to engage specific communities or populations. And many of these existed across Canada. So many situated in Ontario, British Columbia, but we also had representatives in Alberta, Saskatchewan, Manitoba, and Quebec. The ones in red were the Pan-Canadian initiatives, and we did have a team in Nova Scotia, and it was unfortunate and very telling of the times that the family physician leading that team ended up moving away, and so that team was not able to continue. So, and also we had cross-cutting supports and developed a number of different tools. So the CASH team at University Health Network in Toronto, developed a number of tools to support interprofessionalism, again, that were quite specific to primary care. A team at the EQHS lab at Bruyere here in Ottawa developed a number of tools around equity, diversity, inclusion, and accessibility. A team that the Canadian Health Workforce Network and the Mental Health Commission of Canada co-led developed tools around psychological health and safety. Our Indigenous Advisory Committee developed a number of Indigenous health resources, supported in large part by the Indigenous Primary Healthcare Council, and so those exist on our website. And then, as Ruth mentioned, a team that has taken sort of the next steps in terms of developing integrated primary healthcare workforce planning tools. And there are a number of different webinars that are part of our legacy. So I'm just going to go into a little bit of detail about our psychological health and safety toolkit. This is a link, you'll have the slides, but this is a link to the webinar that our team undertook. And this is a link to the toolkit. It's available in French and in English on a microsite that our colleagues at the Mental Health Commission are continuing to host and promote. And it's really important that psychological health and safety is distinct from, addressing burnout or addressing, mental health in general. It's about creating teams and organizational environments that promote inclusion through developing and fostering psychological health and safety. It's aligned around 7 different themes, which build upon the psychological health and safety standard that the Mental Health Commission has developed. And all of the resources are very much relevant for either teams or training programs specific to comprehensive primary care. The Integrated Primary Healthcare Workforce Planning Toolkit is a toolkit that has been co-developed in partnership between the Canadian Health Workforce Network, led by Dr. Sarah Simkin, and Ontario Health Toronto, led by Cynthia Danba. What's pictured here is the step-by-step process that is integrated. And so each of these steps has an associated dashboard that we developed on a Tableau dashboard, and it's moving to a Power BI dashboard. So it's almost ready to release. This is something that can be spread and scaled within Ontario, but it is also an approach that is transferable across the country. We are in conversation with folks in Alberta, in Manitoba, and Quebec to develop this to be quite specific. It really is very much, and the article that will be coming out in the special issue of Healthcare Management Forum for this particular toolkit and the Psychological Health and Safety Toolkit will be coming out in September. And this toolkit will really focus on the engagement because it's based on the premise that health workforce planning is about more than modeling. It's about a conversation and engagement with local decision makers. And to that end, I just wanted to share with you some of the really impactful quotes that we have received from those we've engaged. Catherine Yu, who said, "We've now got a plan of how we can float primary care and get more capacity." Jagger Smith said, "Thank you so much for this toolkit. It certainly raised our capability to do planning in primary care." And Susan Joyce, who is a huge fan of this work is not just useful, it's vital to the work that we do in keeping the system alive. So I'm hoping that intrigues you in terms of the toolkit, and happy to answer any questions in that regard. Just coming to some of the concluding slides, the reach and the impact of team primary care, can be stated in numbers, which are listed here, or over 40 project partners, over 20 primary care professions, over 14 team training projects, and over 100 teams who undertook team-based training, 100 health educational practice organizations, 5,000 learners, 200 internationally educated health professionals. Happy to discuss, the 3 teams that were supported there. Over 100 Indigenous traditional healers of different cadres were engaged and supported through this process, something I'm particularly proud of in support of the Truth and Reconciliation Commission. Over 200 rural family physicians received advanced training, and dozens of online resources, consultations, and tools that are available for everybody to be able to utilize. And we are still continuing to load those up to the Team Primary Care website, so keep an eye out for that. At the end of our project, we issued a call to urge all levels of government to ensure that investments for primary care teams include required policy, training, and infrastructure to support those teams. And that we said in return for that continued support, we would continue to, along this path, that the trajectory that we have impacted by team-based primary care. And you can all still continue to sign this. We did present it to the Minister of Health, the Minister of Human Resources, and to senators. And the Minister of Health did sign on to the call, which was really great to see. So supporting the mobilization, we've created an acceleration agenda, what we can continue to do, mobilizing the knowledge and lessons learned from team primary care, strengthening interprofessional coalitions to advance team training and practice, anchor training and practice for all, especially those with the greatest health inequities, and then advocating for evidence-based policies, practices, and infrastructure needed for all of this to thrive. And I'll have slides that I can come back to, but it has sort of the sub-level for each of these elements, and I'm happy to speak to that and come back to that in the discussion. So just to conclude, team-based primary care or Team Primary Care was funded by Employment and Social Development Canada through the Foundation for Advancing Family Medicine. It was an initiative that I was very proud and pleased to be a co-lead of on behalf of the Canadian Health Workforce Network and the College of Family Physicians. And with that, I would very much like to engage with you in a conversation. So thank you so much for the opportunity.
Thanks so much for a terrific presentation. I'd now like to open it up for any questions. We'll be monitoring the chat, but if anyone wants to come off video, we'd also welcome you to post questions directly. Hearing nothing, I'm going to ask a question of ongoing interest to me. It's about data. So I've really admired the work that you're doing at region level in Ontario to tackle the complex issue of planning for interprofessional and collaborative teams. I'm curious if you could add a little bit more detail about some of the data that have permitted that, and also any challenges you might anticipate in adopting those approaches to other jurisdictions or settings.
Absolutely. Excellent question. So thank you so much for that. Yes, I mean, the foundation for effective health workforce planning are the data that you can bring to the table. You need data on the population side, and you need data on the health workforce side, and then you need to bring those data together. So those different steps that are mapped out in the integrated planning approach in Toronto, first of all, talks about, and they're doing this at a neighborhood level. Who is in your neighborhood? Bringing those data sets together. And we're very lucky that the Ontario Health Toronto team has access to excellent data. So that populates that first dashboard. Who is your population? Some of it's populated with Statistics Canada data, and so that's readily adoptable by others. It includes both census-based survey or about the whole population, as well as survey-based data. So for example, the Canadian Community Health Survey is exploited or optimized for its marginalization index. So you create a dashboard of what your neighborhood looks like. And then your next dashboard is, what is the utilization of health services in your neighborhood? So what your population is, the utilization, and that builds upon the POP grouper methodology. And the POP grouper methodology developed by Kai Hai and Yvonne Rosehart, who's just amazing to develop that, has been utilized in other provinces. So that, again, is a tool for that second dashboard. In our third dashboard, we bring together the data on the health workforce side. And Ontario has invested in a health professions database where there's a minimum data standard across all professions, unfortunately, with the exception of medicine and social work. Social work is not included in the health professions database, so we have to do, some modifications to have a sense of social work's contribution and family medicine. But there are good data on family medicine in terms of visits that we can see. And then on that dashboard, we also show, here are the other, interprofessional primary care practitioners that you could be integrating into your primary care. And then you kind of put that together in terms of what are your projections of needs, what is your projections of capacity, not headcount, but capacity. And do they meet, what's the projections? And we have very modest projections, right? 2, 3, 4 years, 5 years out, like not 20 years out. And then we kind of have another dashboard that looks at different scenarios, like physician retirement, like Sarah's developing a module on long COVID, population growth. And then you kind of put those all together on a sort of a summary dashboard. And so walking through these 5 to 6 different steps enables you to have a much more evidence-informed approach. And so we're doing a video with our planners about how they've utilized this toolkit. And one of the planners said that they used the toolkit to make a business case for them to develop an interprofessional hub to attach patients who were unattached in their community. And that's amazing for us to hear. That's the use of having data to make a case. And what they said is that because the dashboard is standardized across all of Ontario Health Toronto region, it means that you can speak the same language with the decision makers. And the whole impetus of Ontario Health Toronto reaching out to us 7 years ago to develop this was for them to be able to make equitable decisions. So this has really assisted in that regard. So it's a methodological approach that's 100% transferable. The access, there will be different data that populates it in different regions. Enabling access to data, the more that we ask for it, the more likely it is going to be liberated. And the more of us that ask for it, the more data will be available and will improve planning. So this is very much a, building a chateau or a cathedral, one stone at a time, and it requires a lot of people to be involved in that. So I really want to encourage everybody, anything is possible. And this type of approach will help us do that.
Oh, that's so exciting to hear. Thank you for that response. Why don't we go to Eddie and then to the question from Marty?
Thanks. Thanks, Ivy. Great presentation. As always, great to see you. You presaged my question to some extent. I was going to ask, who do you think we actually need to make this implemented at a system level, and what's going to convince them?
Excellent questions. And I think that dovetails very nicely with what I presented. And I'm going to share with you an insight that I came to. I've been studying health workforce, sometimes thanklessly, for about 35 years. And, I started this in a very sort of qualitative approach. I like stories. I like to hear and tell stories. And so I have stories that stick with me. I have stories about internationally educated health practitioners who fall through the cracks. I have stories from the incredibly endemic burnout and stress of physicians and nurses and midwives and dentists and others. These are stories that stick with me. And so ultimately, we want to support those health workers. And the path to support them is through better planning. So because workloads seem to be the most important issue causing all of this stress. So if we could better plan, we would have better workloads. And what do we need for better planning? We need better data. So that's the pathway that I've taken us back. So, although I started off my career in mathematics, numbers are not my happy spot, but I know that we absolutely need this. And so that's one thing. This is the path that we need to get to. This is the destination that we need to get to, and we need to do this to get to that point. My other realization is I thought we should be doing planning pan-Canadian, like I was just, Ms. Pan-Canadian everything. And this process in Toronto has made me realize that planning should happen as close to service delivery as possible, because then you can marry the qualitative data and stories that frontline providers are experiencing with the quantitative data that should be standardized so that we could have an equitable approach across regions and within regions. And so I have really come to a realization that we should create standardized toolkits with standardized data, but those need to be informed by the specificities of neighborhoods and regions and communities that services are going to be delivered. I think that that's a really helpful approach that provinces and territories can build onto. I think it's very much aligned with their perspective that this is our jurisdiction. Parking, that the federal government does run a jurisdiction in terms of healthcare systems. So I think from a pan-Canadian perspective that developing these tools, developing standardized data that help support local planners is the way that we need to go. And I think that that's a message that resonates with regions, provinces, and territories, as well as with the federal government that is always doing this dance between, what they do versus what provinces and territories do. I'm hoping that that's answered your question.
Terrific, thank you. Alexander, I see your question. Why don't we go to Marnie's question in the chat first and then to you. So does the work on interprofessional teams in primary care provide clinical outcome measures to assess how and when the interprofessional collaborative primary care team would be best aligned to which patient acuity groups?
That is such an important and an absolutely huge question. So thank you for asking that. I think the literature on interprofessional care in general, as well as interprofessional primary care, suffers from measurement issues. We are not measuring the same thing. We have, 5 different models in Ontario. There's a model in Quebec that's different from the model in Ontario. Alberta has different models. And so there's the models and who that involves. And then sometimes teams is just people co-located and they're not actually communicating. And in some cases, teams are really working together on a particular project. So it's really hard to advance this knowledge area, this area of science and evidence about, to be able to answer the question, are interprofessional primary care teams more effective? And then what's the what, then what? And even the what isn't standardized to measure. So I think that we need a much better job at creating more functional interprofessional teams. How we would measure what function is, I don't know. But right now, we have a literature that, says 2 different things, that they could be better, maybe they're not better. But what are you actually measuring in that sense? What are you assessing? What's the quality that you're looking at? So I think this field is still really nascent. And I think that we need to advance team-based care. It seems like a logical thing to do, better utilizing all of these different roles that we as a society have invested in, as well as the practitioners have invested in their training. We should make sure that they could do work to the top of their scope, and they should do that together. And ideally, they should be doing that in an equitably funded and regulated system. And it's really only then, if we are moving towards a much more rational system of optimal utilization, can we actually say that things are going to get better. So I know that I'm not really answering the question, but part of it is because we are comparing apples and oranges and pineapples and pumpkins right now. There's no such thing as a team, how we would measure the most functional team, and therefore be able to say unequivocally that that this is better. But it makes sense.
Thank you. Alexander, over to you.
Yeah, thank you very much for the presentation. I really enjoyed it, and I agree that all aspects of primary care should be working together. So I commend you on including dietitians, dental, like all aspects. My main concern is the navigation for the patient through the systems of their primary care. Who takes the lead on navigation through whatever care they need? Would it be the primary care physicians or the organization? Because it would be very difficult for the patient to keep track of what appointments or where they have to go next. So that's one of my I mean, I commend everything. It's just who's going to provide the navigation through the system, and then making sure that there's follow-up and data, collection on, are they getting the treatment? How was so that's one of my biggest concerns with this.
Yeah, thanks for that question, Alexander. That's such an important point. And as you noted in the slides, continuity is one of the core elements of a really good, a strong foundational primary care system. So I would say that the person who should be helping to navigate should be someone fairly accessible to the public, to those patients who are attached, to a clinic, and that person should be knowledgeable about the different roles. And, there was a great team in Quebec that developed sort of an algorithmic approach for triage. I think that was a really, really promising practice that we should look at, spreading and scaling. It was unfortunate that, our project was so condensed in terms of time frame. And what we really wanted to have was a group of medical office assistants or, primary care team assistants who could be trained in all of the different roles to help with that navigation process. So I think that there are tools that have been developed by the different teams in the project that would help with that continuity, would help with the navigation role and the navigation in an appropriate way, and recognizing that there's going to be a lot of learning that is going to have to happen both in pre-licensure programs, post-licensure programs dedicated to those practitioners, as well as in teams. So what we are saying with our call to action is, whenever you're dedicating money to expand teams, make sure that there is an alongside component to ensure that the teams are getting the training that they need to function well together. And that includes a really important role of knowing what each other does and how best to navigate and coordinate care. And so, there would ideally be supports for that so that everybody has access to a patient record, that the patient owns their record, so they can make sure that it's correct, and everybody, puts their, professional insights, into that in terms of, a coordinated care plan going forward. So you've highlighted a really, really critically important issue that absolutely must not fall through the cracks, and that we want to make sure moves forward with our call to action and a lot of the promising leading practices that were developed by many of the teams. So thank you.
Thank you. Quick question in the chat and then over to Dumi. Given what we know about exercise as an effective intervention, it would be nice to see kinesiologists included on primary care teams. Has this been discussed?
Absolutely, and I can't recall whether kinesiologists, because they're a regulated profession in Ontario, and I believe that they may be one of the professions that are included in the primary care toolkit that we have in Toronto. So there was one team that was funded again in Ontario, focused on integrating chiropractors into the team, but also developing educational modules for chiropractors more broadly about how they would need to be trained to not just work in their private chiropractic clinic, but how they could become integrated in primary care. And there's a huge interest in chiropractic in doing that. And I mention this quite specifically because here's the link with kinesiology, that two of the major issues that are presented in primary care are mental health and musculoskeletal issues. And so we can better utilize kinesiologists as well as physiotherapists, chiropractors, depending on who's available in the community and depending on, you know, the regulations, which are always disparate across the country. In some cases, kinesiology is regulated, in some cases it isn't. And so depending on context, how to integrate folks and again, to address the primary presenting symptoms that come into primary care. So absolutely, I think it plays a role. I think there's a way that we can gather data to include kinesiologists in health workforce planning. And I hope I answered your question.
Over to you, Denis.
Yes, thank you, Ivy, for this presentation. Lots of very interesting stuff. Pondering over my questions, I realize it's almost an impossible question, but whatever insight is going to be useful. So when we talk about team working and collaboration and psychological safety, I mean, I would say the word that's not mentioned there is power and power differentials in the medical institution and whatever the historical power of doctors. So how is this being addressed in the approach, and how is this related to, and again, because of the many legal situations in Canada, I'm just thinking about like a clinic in Quebec can be owned by one or two doctors, and there are other doctors, there are other professionals. How is the legal entity in which you're working is facilitating or impeding on team-based care?
Absolutely. So I think that there are some models of care, of clinics, that are more or less supportive of really, truly integrated primary care. From a legalistic perspective, where I thought you were going with this, and it's an issue that came up when we studied this back in 2014 with the Canadian Academy of Health Sciences on scopes of practice and working together interprofessional models of care. And we had a legal review done at that time that there were no cases where the liability of the physician covered inappropriate practices of any other team member. So it was so we developed, there was a paper that was developed, a Mythbuster that was developed on that. And when we were doing team primary care, we also engaged with folks at the Canadian Medical Protection Association, and their guidance around team-based care is that everybody works within their scope, that their regulated scope, and that it shouldn't impede upon the liability coverage of different practitioners. So there's the legal entities of models of practice around clinics. There's the liability context for integrated care. And so I feel the voice of the CMPA is a pretty legitimate voice, and they say that there isn't anything that impedes integrated primary, like integrated team-based care. Coming back to the issue of power, it may not have been salient from the outset. So I identify as a sociologist, and I say it that way because my master's and PhD is in public health. But I'm squarely situated within a sociology department. And so some of my most impactful writings have been on the topic of medical dominance. And so this is very much part of the conversation. I can say very honestly that medical dominance reared its head in team primary care in a variety of different explicit and more insidious, implicit ways. And so the importance of psychological health and safety is not about kumbaya, everyone's going to get together and be happy. That's not what psychological health and safety is. Psychological health and safety is feeling that you can bring up these controversial issues that need to be addressed for the benefit of patients and for the benefit of quality care. And sometimes that creates really crucial conversations that may be very uncomfortable. And so we have a number of webinars that talked about that. We had incidents within team primary care where there wasn't a practice of cultural humility with respect to Indigenous patients, Indigenous practitioners. And so there was a lot of lessons learned about that. So power is absolutely central to these conversations. It requires a lot of humility on the part of everybody. And that is the only way that we are going to be able to move this forward. So there was a sociologist part of me coming along with the ride. So I have this kind of sociology out-of-body experiences with this. And I was sitting there, oh my God, there's a really interesting sociology PhD thesis about this project. And so I'm just going to be like really honest. Those things were salient. They are salient within the teams. They are salient across the teams. They are salient within the whole team primary care initiative. It's absolutely there. And we have to be honest, and we have to put it on the table and confront it going forward. And I think it's for everybody's benefit. That's the thing that I really want to stress. It's for everybody's benefit. Everybody is burnt out for a variety of different reasons. Some of it's work overload, some of it's underutilization, where people don't feel that all of the training that they received is something that they can do. And that causes a lot of disengagement. So there are challenges for a variety of different reasons that our hope is that being able to kind of move that forward. I hope I've answered your question.
Thanks so much. I'm really glad to be able to end this seminar on a sociological out-of-body experience, but really appreciate that the power structures that linger below the surface being brought to the forefront. So thank you for those questions and for that discussion. I think we'll wrap. I see just one more question popping up there in the chat. Maybe we'll try to fit a response to that in before wrapping up. Have you considered the role of data stewards within the team-based integrative primary care, and bringing them to the collaborative design table? Having informational professionals offload the complex health data environment seems to fit with this initiative. Interesting.
Absolutely, 100%. They should definitely be part of the team. They should definitely be at the table, and all of the different practitioners should develop some level of competence in that. I will refer you to hopefully a publication that will be coming out soon, but a really amazing presentation that was done at the CASPA conference by Dax Boursier, who's in Nova Scotia, and Sarah Simkin, a really important vision for how we could better capture data in real time to inform clinical decision-making, but also health workforce planning. And so I 100% support that. And I'm hoping that I answered that quickly.
Thanks so much. Okay, power and data. That's perfect. I want to thank everyone for joining us today. Please join us again on June 25th, where we'll continue the conversation around access. In this case, thinking about the architecture of primary care and what first contact access can and might look like. Also, please complete the evaluation that you'll see when you sign off from this. We'll use that to inform subsequent seminars, and have a wonderful day, everyone. Thanks so much, Ivy.
Thanks, everybody. Thanks again. Appreciate it.